Welcome to Conference Highlights, recorded in front of a live audience at an evidence-based perioperative medicine, that's EBPOM conference. EBPOM are world leaders in perioperative education, so why not join us at our next meeting with a special discount for Top Med Talk subscribers. Look us up on www.ebpom, that's EBPOM.com. Top Med Talk.
Professor Denny Levett, Professor Critical Care and Perioperative Medicine down in Southampton, where she practices both clinically and academically. Denny's a recognised expert in exercise physiology, both in the clinical setting and in extreme environments. She's currently chair of POETS, and Denny this morning is going to talk to us about critical care. Has it got any value for perioperative medicine? Thanks, Denny.
So thanks, David, for that kind introduction. So I've been asked to talk this morning about the benefits or otherwise of post-operative critical care. So I should probably start with disclosure and a potential conflict of interest. So I'm the clinical lead for a post-operative critical care unit. So think of that, take from that what you will regarding my potential biases when we talk about this. So unsurprisingly, when I first asked myself, is post-operative critical care of benefit to our patients, the answer was an immediate, resounding yes. What is it that we do? Well, we optimize them in the post-op period, the hemodynamics, and then we avoid immediate post-op complications. And by doing this, we hope that we reduce the risk of failure to rescue later in their inpatient stay, and so we improve their outcomes. But then I spent a little more time and I considered this a little further, and I asked myself, well, which elements of what we do in intensive care is it that's important for the patient? And actually now I come to think of it, are these needs best suited to the critical care environment? And finally, what exactly is it that I do, or we do on a daily basis, that improves our patient's outcome? And what becomes clear when you look at the evidence base supporting the use of perioperative care, critical care, in clinical decision-making, is that it's very limited. And I think the conclusion really of my talk over the next 20 minutes is that we have more unanswered questions than we have answered questions to some extent. And the implications of this are really important, not only just for the patient in terms of their morbidity and mortality and their short-term surgical outcomes, but we know that being in intensive care is associated with a significant amount of psychological morbidity and an increased risk of delirium, and we've been learning a lot about brain health post-operatively in the last few days. And also it has very significant financial implications, because critical care is very expensive, and we are in a resource-constrained healthcare environment, and we need to make sure we're using our resources carefully. So the questions I hope to cover in the next 20 minutes or so is, first of all, who should we be sending to critical care? When should we send them there and for how long? When they get there, what should we actually be doing to them? Which interventions have an evidence base to support them? And when they've been there, what should we look at in terms of improved outcomes relative to ward care? And before I start focusing on this, I just want you to think for a minute why it is that you might be sending a patient to critical care post-operatively. And I think you can divide these, and there are a multitude of reasons, there's a few I've listed there, into what I would say is treatment indications, by which I mean patients who have established or impending organ dysfunction or organ failure. So the patient with a sepsis preoperatively, multiple organ dysfunction, who then has a laparotomy and is left with an open abdomen overnight with a view to going back the next morning, quite clearly needs to be in intensive care overnight, ventilated. At the other extreme, we have the use of post-operative critical care as a form of prophylaxis, essentially. We're preventing something that may or may not happen. And the problem is we can't predict whether it's going to happen with much precision at the moment. So that leaves us in a difficult position. So what I'm actually going to talk about is predominantly the use of elective critical care for prophylaxis. But I think one should flag up at this moment that one of the problems with the literature base is that we don't often distinguish in database studies between these two indications for admission. And the outcome of patients is going to be wildly different if they arrive in intensive care with multiple organ dysfunction from the ward having deteriorated, as opposed to ones that we're sending there because of something that may happen but may not. And I'm pleased to see that I'm not the only person that's thought that this may be a problem. So I went and looked at the recent Delphi consensus of research priorities in perioperative intensive care medicine, and top of the list was what is the best use of intensive care resources in the perioperative period. So there are a number of us who are thinking that this is an issue. So first of all, who would you like to send to intensive care? Who is going to benefit from the intervention? Now, this is a challenge. You're all familiar with this. We know that there are over 300 million surgical procedures that are taking place annually, and elective mortality is somewhere between 0.5% and 2%, emergency mortality somewhere around 10%, and about 1.5 million deaths annually. And morbidity is 10 to 15-fold this challenge. But within the surgical population, we know that there is a subgroup of patients who are at particularly high risk of poor short-term surgical outcomes. And we refer to these as the high-risk surgical population. And we define those as patients whose inpatient mortality is more than 5%. And there have been a number of retrospective database cohorts trying to retrospectively identify the features of these patients so that will help us, in fact, in future, prospectively identify them. And this is a typical description. This is a study from Rupert Pearce from the UK retrospective database population. And you can see the high-risk surgical population is on the whole older than the low-risk or normal-risk population. And importantly, just under 90% of the high-risk population is having emergency surgery. So reasonably lower risk amongst elective surgical patients. And not only do they have a high risk of mortality, but perhaps unsurprisingly, an increased risk of morbidity as well. So if there is this high-risk group, do we identify them preoperatively? Because surely these are the people that should be in intensive care prophylactically or some sort of critical care environment. The problem is that when we look at behaviour and practice in snapshots of audit studies or cohort studies, we can consistently see that, in fact, we don't admit this cohort of patients to critical care. So if you remember the USOS study from the Lancet, was published in the Lancet in 2012. This was a one-week snapshot of elective and emergency surgery across Europe. And what we found in that study was that 73% of patients who died during their inpatient stay never went anywhere near an intensive care. And so there was no critical care input at all, either immediately post-operatively, prophylactically, or indeed before they deteriorated and died on the ward, which seems really surprising to me. And in the follow-up study, the ISOS study, which included patients from Australasia and the US, 28% of patients who died in that study, so that was elective surgery only, no emergency surgery, and the overall mortality was lower at 0.5%, but still 28% of the patients who died never passed through an intensive care unit. One of the other questions you want to ask yourself is, given that 90% of the high-risk surgical patients are emergency surgical patients, should we worry particularly about elective surgery? And the answer to that is actually yes. It's important to remember this concept of the prevention paradox. And that is, although the risk of mortality is higher in the emergency surgical patient, because there are many more elective patients, numerically the majority of patients who actually die have had elective surgery rather than emergency surgery. So this is from the USOS study, and you can see 1,000 deaths in the elective population and 250 in the emergency population. So the problem is that the majority of the deaths are happening in the lower risk population. And if you translate that into risk prediction, it comes back to that old chestnut of the ASA score. We're good at identifying 4 and 1, but 2 and 3 is more common. 2 and 3 is difficult to precisely define risk in that population, but the majority of people who die after elective surgery are ASA 2 and 3 numerically. And that's one of the problems about who we send to critical care. So on the basis of the data about the high-risk surgical patient, there have been a number of reports, both from clinicians and from the government in the UK, suggesting we should identify these patients and send them off to critical care. So the high-risk surgical patient said if their predicted mortality is more than 10%, they should go. The Knowing the Risk, which was the NC-POD report, looking at perioperative critical care, said more than 5% predicted mortality should go. And then we had the first National Emergency Laparotomy Audit report. And you may remember that this is looking at emergency surgery, laparotomies across the UK. And we found that actually 40% of the high-risk patients didn't go to critical care. And in fact, 11% of the highest-risk patients didn't go to critical care. Now, subsequently, with the second and the third NELA report, interestingly, you'll see that there's a trend towards more patients after emergency laparotomy going to critical care. And we know that over this time period, the mortality in the laparotomy population in the UK has also decreased. But this is association, not causation. But it may be that some of the benefit that has happened has been the elective admission of these patients to critical care. So what about elective surgery patients? Now, this is another Snapshot audit. This was a SNAP-1 audit, which was published recently, where we looked at both elective and emergency surgery again over a 2-day period across the UK. And what you see again is that the vast majority of high-risk patients are not being sent to a critical care environment post-operatively. So we believe we can identify high-risk patients, but we're not sending them to critical care, which begs the question, why not? Is it because we believe or we know that the risk stratification is imperfect? Or indeed, are we actually using any risk stratification, particularly in elective surgery? Is it because of a lack of resources, insufficient critical care beds across the UK? Or is it that actually as a community we believe that the evidence is lacking and we're not sure that anything we're doing there is benefiting these patients anyway, so why should we do it? Because these complications are inevitable in the high-risk patient and we can't avoid them. So first, let's talk about the individualized risk assessment. So when we go back to the NCPOD report, when it says that all patients with a predicted risk of more than 5% should have an individualized risk assessment and be sent to critical care. The problem, as we're all aware, or the elephant in the room, is that we don't have a perfect risk predictor. We do not have a way of precisely knowing what someone's post-operative risk is when they sit in front of us at high-risk preoperative clinic. There are a number of tools that we can use, but the problem with each of these tools is that all the models that exist currently tend to use one tool or another, and then when you do 3 tools, you're not quite sure what you should do with the outcome of the 3 tools, how do you integrate them into one number, and then how do you use that to decide what to do post-operatively. So we have subjective clinical assessment, and if you've read the recent METS paper, that turned out to be rather disappointing. We have objective tools. There's a new area of biomarkers, and that might be something that will contribute in the future. And then there is objective assessment of functional capacity with cardiopulmonary exercise testing, or more subjective tools of functional capacity, such as the DARSI score. The problem, as I said, with all of these individually, and I think the METS study confirms this, none of those on their own appear to be predictively very precise. So we're in a difficult situation. They all add something. I think in the future we really need to have more integrated models that integrate not only function, because that's not the only risk factor preoperatively, but also other comorbidities and surgical factors in terms of predicting risk. What about resource limitation? Is there really a problem with critical care capacity? Well, I think the answer in the UK is probably yes, certainly in some areas. So if you look internationally at critical care bed provision related to head of population, you can see the UK is right at the bottom of that list. And in particular, we have been, although there has been an increase nationally in level 2 type beds, we are still behind other developed nations in terms of the number of beds available to our surgical population. And variation in capacity quite clearly leads to variation in practice. So if you look at patterns of admission to ICU across the ISOS and the USOS databases from those studies, they varied widely, not only from country to country, but from institution to institution and internationally. And if you look at the NELA data, it's quite clear that there's massive variation within the UK as to the number of patients that are sent to post-operative critical care electively post their laparotomy. And finally, what about evidence of benefit? Is there any evidence that critical care is improving the outcome of these patients? Are we indeed avoiding these post-op complications that we set out to do? First of all, there's a problem because we're not going to be doing anytime soon a prospective randomized controlled trial of ICU care versus ward care, because I don't think we'd get ethics, and I don't think patients would probably want to be in the ward care arm. So that means we have to look at database data and prospective and retrospective cohorts to try and evaluate what we're doing to some extent. And so there's been a lot of looking retrospectively at cohorts of data, both from the UK and internationally, and there are some suggestions that critical care improves outcome. So in the UK, this first study here looked at improved outcomes relative to the number of critical care beds. And again, another study in Scotland suggested that some of the variability in mortality outcomes could be explained by the provision of critical care beds. But, on the other hand, there have been other studies internationally that have said the converse. So the Medicare USA study published in 2013 looked at 130,000 elective critical care admissions. They described wide variability for criteria for admission to critical care, and no obvious benefit in terms of morbidity, mortality, and in fact cost increased, which is all a bit depressing if you're a perioperative intensivist. And then we have the ISOS data. So I don't know if you saw this study, but they were looking at outcomes in the ISOS study relative to intensive care admission and relative to critical care bed provision. And they could find no relationship between in-hospital mortality that suggests critical care is protective in any way, shape or form. So as you can see here, 2.4% mortality in patients who went to critical care versus less than 0.5% into those who went to the ward. Now, is it really that we are harming those patients that are going to intensive care? And if not, are there other possible explanations for this variability in the data? Well, I think there are several explanations. And first, and probably the most important, is this concept of confounding by indication. On the whole, we choose patients that we think are the most sick to go to intensive care. The only way you can control for that when you follow patients prospectively is to risk adjust at baseline. And if your risk adjustment model at baseline, which is trying to even out comorbidities and sickness, essentially, is imperfect, then you're going to have confounding factors. And I think that's going to be highly likely if you look at those studies. They're relatively blunt tools, our risk adjustment currently. Secondly, certainly for the ISOS study, the definition of intensive care was perhaps non-standard. Now, those of you who have a PACU or a high dependency area or a level 1.5 area, you may not have come under critical care when the definition in ISOS was that you had to have the availability of 24-hour ventilation. So in my hospital, we have a 10-bed elective level 2 area where we're able to use vasopressors and many other things, and we have a 2-to-1 nursing ratio, but that would have ended up under ward care in that study. So be a little bit careful of that. And then finally, there's this issue that there was no distinction between emergency and elective admissions. So is there any data anywhere that suggests something that we do in critical care is beneficial? Very little is the answer. I was a bit disappointed to find. But there was this study which was published earlier this year in the BJA. Now, this is a small single-centre study looking at elective colorectal surgery. So that's the caveat to start with. This is from Torquay, so Mike Swart and John Carlisle. What they have developed over the last 10 to 15 years is a prediction model looking at the predicted mortality post-operatively, which is based on a combination of comorbidities, known life expectancy at a certain age, and also objectively measured functional capacity with some CPET variables in it. And they've validated that locally and nationally in the terms of aneurysm patients to see that that's valid at predicting their local mortality. And so what they do there is stratify their patients based on that predicted mortality. And so this is, as I say, 500 elective colorectal patients that routinely in the UK clearly don't all go to intensive care. We try and identify the high-risk ones and send them there if they need to, or HDU environment. If the predicted mortality was more than 4%, they went to intensive care, or HDU in this case, and if there was not a bed available on the day, the case was postponed. If they were under 1%, they all went to the ward. But there was this intermediate group, the 1 to 3%. And what they said in this group is ideally this group would go to a critical care environment, but if there's not a bed available on the day, we'll do what the clinicians on the day think is best. So is it best to delay the cancer surgery and come back another day, or should we just cross our fingers and toes and proceed and plan to go to the ward post-operatively? And I think the outcomes are really interesting. So first of all, in that very high-risk group, even the ones that went to critical care, post-operatively, did have some. So these complications, this is emergency laparotomy, so it's not a small complication, and this is an emergency unplanned critical care admission, so associated with significant morbidity and mortality. And what they found was 9% risk and 4% risk. Reassuringly, in the low-risk patient, there was low incidence of major post-op complications, but most interestingly, if you look at the patients that went to HDU, electively, post-operatively, there were no repeat emergency laparotomies and no unplanned critical care admissions, whereas these guys that went to the ward, who were of equivalent risk, equivalent baseline risk and comorbidities matched, you can see had tenfold the rate of anastomotic leak and relaparotomy and a high risk of emergency admission to critical care. And in terms of costs, that translated into being more expensive. So there is some light at the end of the tunnel. Something that we do in HDU is improving outcome. Finally, what do we mean by critical care? When you send someone post-operatively for prophylaxis, do you need these things, organ support, or are you looking for nursing care? I would suggest that it's the second element that we want. We need to start thinking about what we deliver in critical care. And we need to start thinking about changing our models of care. In intensive care, we're not good at mobilising patients. We're not good at feeding patients. It is probably not an environment for the well patient who is just there for monitoring in order to be able to intervene early. We should be thinking perhaps of moving more towards this sort of model of a 1.5 level care, and I've stolen this shamelessly from Michael Swart, changed a few things on the slide, but essentially we want high-level nursing care with some monitoring, and we need to mobilise and do what we should do for Aris principles. There is a lot of known unknowns, and we need to understand more about the interventions we're delivering in critical care to know if what we're doing is beneficial. This is what we know. We know that there is a problem with availability of beds. There's no conclusive RCT evidence to support critical care being beneficial, and we need to remain alert to the possibility that some of the things we're doing are harmful to patients. We need to know more about the best method of risk stratification, which model of high dependency care is most suitable, which critical care interventions work, and how long patients should stay in critical care. And I hope that Ramani later is going to tell us the answers to all those questions when she presents the early data from the SNAP2 study. Thank you.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.